Buenos días, gracias por conectarse a nuestra reunión semanal de los jueves de directores médicos. Como bien saben, la forma en que elegimos los temas es siempre la misma en la comisión, que es preguntarle al grupo cuáles son los temas que les interesan. La encuesta de los lunes nos permite identificar los temas que están con mayor grado de interés. Los días martes, Chantal circula la tabla con las respuestas, la conversamos con el grupo coordinador, con Robbie, Roberto, Andrés, y en base a donde parezca estar la mediana, elegimos el tema, de ahí que sea importante, y los invitamos a responder la encuesta de los lunes, toda vez que tengan ustedes un tema identificado de interés. Ya sabemos que les gusta recibir los llamados de Chantal los martes, pero en la medida en que contesten los lunes, son algunas llamadas menos para ella. Y nos quedó muy claro que el tema cirugía en época de pandemia se había vuelto central. Ya afloró en las encuestas de las dos últimas semanas e incluso en los debates de las reuniones precedentes surgió, si bien los temas eran otros, surgió en forma reiterada como un tema importante y de inquietud para todos. De manera que aquí está, y a la hora de poder pedir a alguien que nos diera alguna orientación acerca de cómo hacer convivir con seguridad y en manera adecuada la cirugía con la época pandémica, pensamos en poder convocar a un centro que todos identificamos de referencia regional e internacional, y además en un país que por su población y distribución del COVID-19 tiene más experiencia que nosotros lidiando con la convivencia de ambos aspectos. Hemos extendido invitación también a colegas de las asociaciones colombiana y mexicana de hospitales, así que es probable que se estén conectando y se los vamos a presentar si así fuera. Y le voy a dar la palabra a Chantal para que nos recuerde, para aquellos sobre todo que sea la primera vez que se conectan a esta reunión, cómo es la mecánica y las reglas para poder hacer preguntas y participar.
Ahí está. Gracias, Gerardo. Bueno, buen día a todos. Gracias por acompañarnos un jueves más. Simplemente quiero comentar que, como en todas las reuniones, los micrófonos van a permanecer silenciados y una vez finalizada la presentación, aquellos que quieran hacer una pregunta o comentario, les pido si por favor pueden solicitarlo por el chat del Zoom. No por WhatsApp ni levantando la mano. Si puede ser por el chat del Zoom y en lo posible de manera privada. ADECRA+CEDIM es ideal. Bueno, eso es todo. Muchas gracias.
Bien. Como saben, nosotros, al menos varios de nosotros, no hablamos buen portugués, y nuestros disertantes de hoy no están muy cómodos en español, así que la reunión, la presentación y las preguntas van a transcurrir en inglés. Si alguno de ustedes no se siente cómodo para formular preguntas en inglés durante el debate, les damos la opción de escribirlo en el chat y alguno de nosotros, Javier o yo, los vamos a ayudar con la traducción. So, welcome to our meeting. When we talk about addressing the problem of elective surgery and major surgery during the pandemic, we try to identify whom to ask for advice. And we all know that when we need advice in terms of patient safety and quality of medical care, we often look up at Albert Einstein for counseling. So it is our privilege to have today as speakers Dr. Leonardo Rolim Ferraz. He's head of the critical care department at Hospital Israelita Albert Einstein. Dr. Ferraz did his medical training in Sao Paulo at the University of Sao Paulo. He also has an MBA in healthcare management from INSPER in Sao Paulo. And he will also introduce Dr. Namjin Kim, who is in charge of the surgical programs at Hospital Israelita Albert Einstein. So thank you so much for your time, for your generosity in sharing your knowledge and experience with us once again. A couple of years ago, we had the privilege of having Dr. Miguel Cendoroglo as a key speaker at our annual meeting. It was actually thrilling and a great experience to know from him, learn from him, and appreciate his generosity. So thank you again. Also, thanks to Sofia from the counseling department at Albert Einstein. She's been very generous and very dedicated as well to help us build up this meeting in a short notice. So thank you and welcome.
So thank you very much. I'd like to ask to share the presentation. First, before we started the presentation, I think I have to say thank you for the opportunity to learn with you. I think that we are facing, we are on a time that with radical uncertainties and unpredictable changes. And the best way to lead with this scenario is to help each other, support each other through sharing knowledge and experience. So thank you very much for this opportunity to learn with you. The second thing is that I have to, in the name of Dr. Miguel Cendoroglo, apologize, ask for sorry for you all. Unfortunately, Dr. Miguel is now in other live talking about the same issues, and he asked me to replace him today. And I think that to replace Dr. Miguel at the same level, one person is not enough. So I asked Dr. Nem Jim Kim to join us. So two people, it's better, and to replace Dr. Miguel at the same level, his expertise. So please, Dr. Nam, the next one. We're gonna, you already know the subject or our presentation. It's how to back to work for elective surgical treatment, how to build a safe flow. We're gonna share the presentation. I'm gonna start with the consequences of the COVID-19 pandemic. And Dr. Nan is gonna share how Albert Einstein is dealing with this scenario. We already have a plan and implemented these steps to build a plan to come back to surgical procedures, elective surgical procedures. No, it's not working. Sorry. Could you come back, please? Yes. So we're going to start with sharing this graphic. It's not published. It was tweeted. It's a sign of our time. Was tweeted with a colleague of us, Dr. Victor, saying it's a critical care physician from University of Colorado, and was a huge success. Tweeted a lot because it make a lot of sense and it's happening. So this graphic shows the phases of the COVID-19 pandemic over time, what are the health footprint of pandemic. Usually we think that it's only one wave related to immediate mortality and morbidity of COVID-19 infection. Actually, we have other waves, more waves hitting the society and the healthcare system. So besides the first wave related of infection itself, we have 4 waves. The second wave is the impact of resource restriction on urgent and non-COVID conditions, and also impact of interrupted care on chronic conditions. So these 2 waves, it's not only regard of closed services lines and reallocation of the resources to take care of COVID-19 patients, but also because of the behavior of the population that here in Brazil, there are a lot of fear of people and fear of the physicians to resume elective procedures or to seek their physicians, their doctors, or to come to the hospitals. Fear of getting coronavirus. So it's more complex than only the viability of the research. Are also behavior aspects of the population and the healthcare workforce. And the fourth wave, it's probably the bigger one, and it's related to mental illness and the economic burden that will come and influence the social determinants of health. So the scenario is very complex. It's not related only with the COVID-19 pandemic or infection or take care of these patients. It's also disrupting all this system, the healthcare system, in different waves and at different times. If we analyze the pandemic curves and the impact of the pandemic on delivery of surgical services, we can see that if you have high peak, as in Brazil, we are facing in public sector a peak of the pandemic that is above the threshold of capacity of healthcare system. And in this scenario, of course, that we're gonna have the inability to maintain emergency services, and we're gonna have death related not only to COVID-19, but also to other diseases like surgical urgent procedures. But all the countries, and Argentina, I think it's a good example, are trying to have suppression and mitigation strategies to suppress the curve. The problem is that with the suppression and mitigation, we're gonna have a long tail of the pandemic curve. So we're gonna see this pandemic last for months, and the impact is gonna be not only on the short term, but also in the long term, and delaying surgery and compromises prognosis of the surgical patients and in the next month. So I think that we have pay attention, and because we usually in Brazil a lot of discussion about this early phase of the COVID-19 pandemic, but the impact and the long term on the not only the surgical patients but in the healthcare system, we have to be prepared and have a plan to deal with the long-term consequences of the pandemic, especially in the surgical patients. We have a lot of evidence in the literature about the impact on research restriction on urgent and non-COVID-19 conditions, like this paper of New England Journal of Medicine published by Kaiser Permanente team, showing that in the last 2 months, a reduction of 48% in admissions of patients with acute myocardial infarction. And in these patients, part of these patients are having myocardial infarction without treatment. It's not only the reduction of disease, it's reduction of diagnosis and treatment. This other paper showed the same thing, the reduction and 38% on using of cath lab treatments of patients with STEMI, with myocardial infarction. 38% reduction of treatment of patients with the best treatment for STEMI is not being used because the patients are not going to the hospital seeking care, even if they are sick at home. Another example is with stroke. This is analysis of 800 hospitals in the US, showing that the number of CT scans that was ordered to evaluation of stroke patients dropped more than 30%, almost 40%. So it's a lot of examples that we are facing a reduction of use of best care and not using our system to treat patients with other conditions than COVID-19 disease. Oops. And how long we can wait to take care of the surgical patients? This is a very interesting paper that describes which is this safe postponement period that you can wait to have a surgical performance for oncologic patients, for cancer patients. The median is only 3 weeks if the first surgery is necessary, or 8 weeks if the surgery is an neoadjuvant. So if we have only few weeks before we compromise the prognosis of these patients with cancer. So probably this postponement of this kind of patients, the oncologic patients, is already making harm, because in Brazil, I think like Argentina and US, we have almost 2 months of pandemic, and the patient is not taking his procedures at the right time. For example, in Brazil, if you take the numbers of our public health system, the SUS, in 2018, we have 2.4 million surgeries performed. And we estimate that almost 30% of elective surgeries was not performed due to COVID-19 pandemic already. Probably is going to be more than that. So only if with this number, more than 600,000 elective surgeries we're going to be in line. These patients are going to wait for making these procedures. If you assume that each surgery you're going to have 3 consultations, 3 appointments, going to be more than 2 million of consultations on backlog waiting to be done. So this is burden for the system is huge, not only considering the diagnostic delay and the compromise of the prognosis of these patients, but also the burden that the system is going to have to deal in the next month, in the next years. Numbers in US, this paper said that if was delayed by 3 months elective surgeries in US because of COVID-19, you're going to have 5 million surgeries postponed. And this is a huge number. I don't know if you already have numbers in Argentina, but it's huge. And I think there is a quote in this paper that's a very nice quote that said that elective surgery is not optional. it can be considered non-urgent at this point. Postponable does not mean unnecessary. So this concept that elective surgery is not optional, I think this is a strong message for our institutions, for our patients, for our populations, and the point that we cannot wait until this pandemic finish. We have to take action now. So for me, the main point that I'd like to make is that we are having patients suffering without the proper care, suffering at home. We're gonna have people dying. We're gonna have patients with their prognosis compromised because of lack of access or because of the delay in come back to the surgical services line. And I think our systems, our institutions should act now to build a new normal, to resume our surgical lines as soon as possible, even before the pandemic finish. So I'd like to ask Dr. Nam to share with us which are these steps, which are the plan of Albert Einstein to resume surgical elective procedures here in our hospital.
Ok, buenos días a todos. Tengo que primero disculparme por mi español es muy malo, so I'll keep speaking in English. First of all, this pandemic situation, as we said before, is a local pandemic situation. This is fun because it's a different situation because it behaves as a hotspot. So in many countries, in many provinces, your local province have no cases, but your neighbor province they have a lot of COVID cases, and this is what we see here in Brazil also. And it behaves different even in the same province from private practice and public settings. So now here in Brazil, the private hospitals are have less cases of COVID, while the public beds are full of COVID cases. So there is no one clear formula. It's really hard for our medical societies to define guidelines to back to work situation, because you cannot even say one rule to define how to get back, because you have different settings in different situations. So we are gonna share how here in our hospital we started to define the safe flow to come back. So before moving on, you have to build a new contingency plan. So if everything goes wrong, you have a fast action as a new contingencies to go back. So before you move on, you have to have all your cases in real time. You need to know your capacity of beds, your staff and equipment and ventilators and PPEs. So your patient, the reason why we stopped everything is to take care of COVID patients. And since there are no more or less COVID patients to take care, you have to go back and take care of other non-COVID patients. But these patients, they have to be taken care with all the safety possible, so they will not be exposed to further more morbidities to their recovery. So first step is to build a new contingency plan. When you move on, you have to know when to stop and when to go back if there is a second wave or third wave of COVID, as they say. When to resume surgery? So this is a $1 million question. So if you look for every societies, every institution, there is no general rule. First of all, you have to respect all the local authorities. You have to consider resumption very carefully after evaluating all the context and all the situation of each location and each system. If we follow the roadmap, the American College of Surgeons and Society of Anesthesiologists and American Hospital Association, you need at least a falling trend of COVID cases for 14 days. And your local capacity has to have, you need to have the capacity to offer proper care for all the surgical patients. That means not only not having COVID cases, you need your blood banks to be full again, you need all the ICU care beds, you need all the PPEs, and this for all the COVID situation and for all the non-COVID situations also. Which surgery should I resume? Okay, all the urgent surgeries, we are not talking about this, right? So just like Dr. Leonardo said in that article and the paper in the Annals of Surgery, elective surgery is not optional surgery. When you postpone a surgery, it does not mean that this is unnecessary. What is the main reason we postpone the elective surgery? Because we want to take care of the COVID patients. So there are no COVID patients. Okay, we have proper all the equipment, all the structure necessary to take care of the other patients. Okay, do we have safe flow to take care of these patients? Do we have all the structure, all the equipment we need? Okay, so this is the time, and this is all the surgeries. You have to consider to resume all the surgeries, but with the proper indication of the surgeon, considering all the present situation. And the most important thing, you have to share this decision with your patient. There's a patient of mine. I'm a general surgeon. I had a right colectomy scheduled right before the pandemic. This is an 80 years old patient, and this patient was really scared, and so he said, "Can I postpone my surgery?" At the first moment, I said, "Okay, we're gonna postpone this surgery. That's okay. We can wait for a few weeks." And then a month passed, and we talked to each other again, like by telemedicine, and we said, "There's a reason we postponed your surgery. This is about COVID, and COVID seems not to be going anywhere. We're gonna live with COVID for a very long time. There are not vaccine or any other proper treatment. So if there is a safe flow to take care of you, and we are safe that we can take care of you without any other giving you the proper treatment, we should resume and reschedule your surgery." But he was not confident again, so we scheduled again one more meeting next week with all the family, with all the daughters. This is a upside from the telemedicine, because you can contact all the family so they can join in this decision and to decide if you're gonna resume this surgery or not. So indication remains with the surgeon, but you have to share this decision and to remind everyone that postponable surgery, not being urgent, does not mean it's unnecessary. Okay. So the next step is you need a pre-surgical screening protocol. This is really hard to say because we know the situation is different in each setting. Not all hospitals have PCR for COVID, but at least you need have a screening starting by questionnaire. So we ask every patient if they are in proper isolation, proper social distancing, if they have contact with anyone who had been tested positive for COVID, or anyone who had respiratory symptoms. And we ask about himself, if he has any other respiratory symptoms, and the person's gonna join the surgery, but he be his companion during his inpatient time, if he has any symptoms. After that, here in hospital, we send home. We send home. We collect their PCR test in their home. We send a special unit to their to their home, to their places to collect this test, and then we have a proper flow to the patient we think it's suspect or under investigation, we call it also, or for the patient they are negative. So this is an example for our patients who've been tested. We are sorry for this PowerPoint, it cannot be translated at the time. So we have a proper flow in different doorway, in the input, in the output also. So we collect this exam at home 48 hours before the scheduling time of the surgery, and we put this questionnaire to the patient and who's gonna join during to his inpatient time. His arrival to the hospital is through a dedicated gate, and there's someone there waiting for them. And we have also a thermal camera with artificial intelligence who scans the person to check if he has fever or not. And we have a second check manually doing with the hand thermometer. And there's a concierge waiting for this patient, and then he takes this patient right to his apartment. And while he is in this apartment, and this apartment is in a floor dedicated for non-COVID patients, there's a staff dedicated for this team for the care of this patient. They have routine temperature measurement for the patient and for the companion who was there. In the surgical setting, we have positive pressure rooms. This is as usual, okay? Since this patient is not non-COVID and he has no respiratory symptoms, we have a positive pressure room for the patient, and we have a dedicated staff also for this surgery. But our infection control staff recommends that even though this patient has a negative PCR for COVID, all the staff and all the surgical staff must wear full PPE for the procedure. And even in the discharge of this patient, he has a complete separate doorway. So from the arrival to the way out, he has a complete and separate building for this treatment. He has a complete separate operating theater for his treatment also. For all the patient who is under investigation and has symptoms, or he is an urgent case, we had this visual sign. This is not red in purpose. This is orange, so we can flag, but not that much. And we have a separate flow, and we call it exclusive flow, for the patient who is under investigation or for confirmed cases. So if this patient has COVID, positive for COVID, or his surgery, or he is under investigation, or even though he is positive, but this surgery cannot be postponed, this is an urgent and an emergency, he has he has also a separate place to arrive in the hospital. He has a concierge waiting for him also, and he goes through a dedicated elevator and a dedicated corridor and a floor entirely dedicated for the COVID. And he has also a staff that take cares only for the COVID patients. All the operating rooms are in negative pressure, so we cannot spread. So we avoid spreading all the virus in the possible virus spreading situation. We have also extra care situation. We have filters and smoke aspirators. So we know already. We have papers also. Even though this is few cases, we have some cases in published already about COVID virus detected in peritoneal fluid also. So the spreading risk is real. So this is extra precaution for mainly lab surgeries. And also this patient has a separate discharge way in a different doorway. So from the arrival to his discharge, this patient does not meet each other. The staff does not there's no crossover of the staff. And even the operating room, they are completely in different operating rooms. So in different operating theaters, we have two operating theaters very far from each other. So and in one is block A block, and in the other one is in D block. So this is very far from each other, and so we make it pretty safe here in the hospital. The step 5 is while you're caring for your patient, don't forget to take care of yourself and your team. So even though all the guidance, all the proper testing, don't forget to use all the PPE, even though you have a negative COVID-19 cases. We know that all the tests we have right now, it has a different efficiency. So even you have to protect yourself in any situation, you have to go under any procedure. Also, you have to check your team. It's very usual for ourselves, like doctors, like physicians. If you have a runny nose or sore throat, you just don't care much and just keep working. This is how we used to do always. But now, like for all the symptomatic carriers or very little symptoms, you have to always create a routine for checking and ask proactively your team about any symptoms or creating a test flow for COVID. Here in the hospital Albert Einstein, from the very first beginning, even though we had a little test for our patients, we saved a little safe amount of test kits to test all our medical staff. So any medical staff who needs to be tested, they had this test right on the way and free of charge, so they could be available for all medical staff. So this is very important. So you will not be the carrier of the virus for your patient that you're willing to treat. So this is the situation now. This is what patient thinks about the hospital. This is really hard to convince, to make the patient's mind to come to the hospital. I have a lot of patients calling me, say like, oh, my belly hurts and I have a problem, but he does not want to come to my office to see me. But the reality in most hospitals is like this: empty beds, and all the systems are going to collapse if we keep it this way. So this is what we have to do. We have to, all the physicians and with the administrative staff, we need to build together a communication plan. We have to make sure that it's not enough to have a safe protocol. So it's not enough to have to publish protocols saying that we have very safe protocols for all our treatments. The patients need to, you just scrubbing your hands with alcohol. You have to put the alcohol in front of your patient and scrub your hand. So he's gonna see that you just clean your hands. This is what's going on right now. So, and even for our doctors also. So for the patients to feel safe, our medical staff needs to feel safe. So we have to anticipate any questions. We know that many measurements we take right now does not affect, that does not have any scientific evidence. Just like we started here in like a trial to cover like when some patients does not want to come to the hospital because they don't want to leave the car with the valet. So we put masks in all of them. We put alcohol towards for the handles, for the car seat. So they're gonna see that we are really taking care of them. They don't want to sign anything because they don't want to touch your pen. So these little points, it has to be observed, because just like when you do a major surgery, you save this patient's life and the stitches are a little rough. Their major complaint is, this doctor, this surgeon is very bad, because you see, can you see the stitches? These are looking very bad. So this is what patients care. So it's not enough to, you have a safe protocol, you have any international complaints, you have to be able to transmit this. So this is an video we had. So we have a series of all kind of videos to show the safe flow for our patients, for the surgery, for all the testing, for all the exams, and for all the office consultations also. So
Sorry, doctor. We are not listening the video. If you can put share again and click in.
Sorry.
Thank you.
So I'll just narrate over, do a voiceover. This is a video where we show all the steps we said in our 7 steps. So even for your companion, they get a meal inside the apartment, so they don't have to go out the room if they don't want. So we think that giving these short videos, so our strategy, there is a other problem is like, you cannot it's really hard. Okay, I'm back. It's really hard when you have different situations for different hospitals. You share this kind of video saying that we are okay, we are all good, please come back. And maybe there's a hospital nearby you having bad situation, and this is not gonna look okay. So these videos are sent to our surgeons or our medical staff so they can send to their patients. So this is always through our physicians, so they can feel safe first enough to take all their activities back, and they're gonna talk and share this decision with their patients to bring them back. So just like Dr. Leonardo said, patients are dying. We are postponing really important surgeries right now. We have to take this back. Elective surgeries are not optional. Postponing surgery means, it does not mean they are unnecessary. We need to take back, or our patients gonna die. We're gonna die because we're gonna be out of our jobs, our hospital will close, and all important, very important subject. And congratulations for this meeting.
Thank you so much for your presentation. As always, we appreciate that you gentlemen at Albert Einstein are not only knowledgeable, but very generous to share your experience with the region. And it's very positive for us to can hear from you and learn from your experience. We are now open for questions and discussion. Por favor, recuerden cuando quieran hacer preguntas, escriban en el chat en privado a ADECRA+CEDIM. Chantal va a administrar la secuencia de las preguntas, ella lo hace muy bien, como ya sabemos. Entonces, anótense en el grupo, en el chat, para hacer sus preguntas. Si alguno necesita traducción, por favor aclárelo en la pregunta. Y como cortesía a nuestros disertantes, no olviden decir su nombre, la institución y la ciudad o país al cual pertenecen. Cedo entonces la palabra a Chantal para coordinar. Está silenciada, Chantal.
Muchas gracias. Bueno, empezamos con Andrés Torn, que es de ADECRA+CEDIM, miembro de la Comisión de Directores Médicos. Andrés, Bernardo, no le... Ahí está.
Oh, thank you very much for your excellent presentation. I would like to make a comment and a question. My comment is that at the beginning of your presentation, you said that in order to resume scheduled surgery, you need to have a sustained decrease in the number of COVID cases for a couple of weeks. That is not the case in Argentina. Due to our quarantine measures, the cases are increasing, but very slowly. The curve is very flat, and we have a huge number of surgical capacity and beds available. So I think a key point of your presentation that we don't know what is going to happen, so we have to have metrics in order to resume safely scheduled surgery nowadays and know when to stop, because probably the cases will come. And the question is, how all the measures you described obviously take a very high burden on your budget. There's an overcost for care. How do you deal with that point?
Let me try to answer this question, and Nem can also answer. So I think that one point that Nem said more than one time, that we have to deal with this situation at local with a local strategy. Here in Brazil, the burden of the pandemic is completely different between cities, between systems. In the private system, the scenario is completely different from the public system, and even between hospitals, the situation here in Albert Einstein It's completely different from other hospitals, even here in São Paulo. So I think it's very important to, I think that it's not the case to see the overall scenario. Like in Brazil, yesterday we have 1,000 deaths. So, and the numbers are increasing, like 18,000 more cases per day. If I took these numbers as a measure to take actions and make decisions, we didn't have to resume elective surgeries 20 days ago. But our situation, the people that we serve, our population, our system is completely different from this scenario. So I think it's not possible to make these decisions based on overall numbers. You have to have in account your numbers, your population that you serve, your city, your system, if public or private. So this is my answer to this question. And the second one, it's yes, we have a lot of concern about the impact on the economic impact in our system, in our hospital. Last month, between February and March, it was like we have 50%, less than 50% of occupation. And we have to invest a lot to build more capacity, waiting for the wave that didn't come. Like I am the head of critical care department. Usually I have 120 beds. I have to make a plan to increase capacity to 250 beds. I invested with ventilators and structure, people, and the wave didn't come. We already take care of more than 200 patients in the ICU, but we didn't need 200 ICU beds. So I think that we are dealing with the burden of the investment necessary to be prepared for the pandemic. And here in Brazil, in private sector, the demand didn't come. The revenue also didn't come. So now the situation is that the hospitals are empty. And to deal with this economic burden, it's other reason to resume service lines, to make sure that we can be able to treat other patients in a safe way. As Nam said, it's necessary not only to have this plan and build this capacity, we have to make sure that the physicians and the patients feel safe. We have to convince them that we are safe.
I guess the other point is like, just like Leonardo said, we have to keep in mind our hospital numbers. Just like Einstein has 60% de público, mais ou menos. Like 60% of our Einstein system holds for public setting. So we are working with the pandemic in the other side also. So we are not forgetting them or not giving any assistance to the current situation. So in the public setting, they are full and they need help. So we are still helping them. But in the private setting, that actually this is where all the revenue happens, right? So we need this to keep holding all the other structures. We had our most higher cases number in the mid-April. So we have lowering tendencies of COVID cases for and sustained for several times, and we feel safe since we have a plan to go back anytime we need. And the other questions that we have to make to ourselves is, how long are we gonna wait? If not now, when? This is what I say to our patients. Okay, you don't feel safe to do the surgery right now, so when do you wanna do this? Next month? Are you gonna feel safer? Or maybe in 6 months? Can you wait 6 months? COVID is not gonna be away. Still, if we're gonna live with COVID for a very long time, there are not proper vaccines being developed, and still, when they come and be effective, it's gonna be more than a year. So how long can we wait to resume all the surgeries, all the treatment? So more than when is how long can we wait? So if we cannot wait 6 months, 1 year, the right time is right now, since you have the safe way to resume the procedure.
Thank you very much.
Thank you. Now, Dr. Joaquín Álvarez Garzón. Joaquín, doctor Álvarez Garzón, ¿está ahí?
Yes.
Okay.
Yes. Do you hear me?
Yes, yes.
Yes, I would like to know that currently for COVID-19 negative patients, what is your current personal protection equipment in the OR block?
Thank you for asking, Joaquin. For COVID-19, for COVID positive patients and negative patients, we, regardless their test, we are using all the PPEs necessary, since we are not quite sure for all the false positive cases. So we have to protect our staff as much as possible. So all the face shield, N95 mask, and all the garments we need, we are using all of them. And extra precautions for during intubation time, all the necessary staff goes out the room, and then during the intubation time, and even in the lab, mainly in the lab surgeries, also we have extra precaution for the gas and aerosols that it comes out, dissipates from the surgery also.
Thank you.
Thank you. Now, Javier Sala Mercado from Hospital Cardiológico de Córdoba. Javier. Ahí está.
Thank you very much, Chantal. Excellent presentation. It's a pleasure to have you present to us what you're doing. I had the opportunity to actually visit Albert Einstein twice in the past few years, and I'm always impressed with the type of medicine you guys do there. So I have two questions, actually. The first one is, you mentioned that, and then we are seeing this here too, you know, and this goes also with Dr. Andres Thorn's question, the first one. We're seeing no wave here, actually, in the private sector, okay? So we just see a couple of bundles things that are going on in different cities, but just it's the same situation that you're seeing there. We prepared, okay, for the wave, and the wave didn't come here. But we do have the regulations, and we also do have the private insurers that are questioning us going back to surgeries, okay? So the question is, how did you deal with the regulations, okay? Because you still have the city regulations and the government saying, you know, what you need to do. And how did Albert Einstein deal with that to be able to resume surgeries? Okay, so that's the first one. And the second question I have is actually, what's the limit, okay, to when you will go back actually to the contingency plan? Okay, so what's the tipping point to go back and cancel surgeries again? And thank you very much again.
Okay, excellent question, Javier. Thank you. So here in Brazil, we have we have called ANS, that regulates all the private insurance companies. And in the early March, they decide that all the surgeries, elective surgeries must be canceled. In the early March, they said all the surgeries must be canceled. And then they came back, and then in the in the early April, they said, okay, we're gonna go back, forget about that, and then this is all about you, doctors. Whatever you decide is important, you can resume the surgery, since you have to just write it down and explain to us that this is important. It was, of course, it was not for, there was a purpose behind that. There was all the hospitals, there was a huge lobby of hospitals with the insurance companies saying, if we die, you're gonna die and no one's gonna survive. You have to take that back, and all the patients are suffering. So they went back with this decision. So since April 10th, if I'm not wrong, we are able to resume all the surgeries, since they are evaluated properly by the physician. And about your second questions, we draw a capacity line about our COVID patients and non-COVID patients. We had a team, we have two teams working here since January. And so we were monitoring all the COVID cases since China and spreading to Asia, to Italy. And then that's how we tested the first case of COVID here in Brazil. So even though CDC was saying, they were saying that, oh, you have to test only China cases, we were testing all the cases with respiratory symptoms coming from abroad. So before they put Italy on the list, we found out the first case coming out from Italy. So it was a couple of days before they said it was important. And since Dr. Miguel, he led two teams, about the crisis and how we're gonna deal with COVID. And then he led a second team in parallel about how we're gonna take over, how we're gonna do the comeback. So these teams were working in parallel and dealing with COVID and non-COVID capacity, and drawing a line how our capacities work. And this is an imaginary line, okay? So this is like 80% of occupancy. This is time to stop, shut down all the elective surgeries again and go back. So we need to answer for the pandemic. So if you go back for like 60%, okay, resume it again. But this is a huge effort, right? So once you cancel, all the effort you made to transmit safety and like safe flow for your patients are gone. All the effort you said, this is a safe place, you can come, this is gone. So we are working very close and praying every day, so it's gonna be safe for all, and we don't have to take back, but we're ready to go back whenever we need.
Yes, I'd like only to add that the effort to resume is huge. It's not easy to convince people, patients, families, and also physicians that we are safe. So we started this effort like 1 month ago. Like this plan was launched like 20 days ago, and we are now seeing the effects. Like usually we have 150 surgical procedures per day, and now last month it's like in March 20 procedures, between 10 and 20 procedures per day. Now we increased like 50 procedures per day. Last week, like 70% of occupancy in the hospital. But I think it's gonna have a long time, a long trail to resume the volumes that you used to have before the pandemic.
Yeah. Thank you very much.
I guess it's about the message you send to the patients, right? If you send a message that the situation is about COVID, they're gonna be afraid to come back. And this is not only for the hospital survival, this is for their own safety. If they don't come back, we see a lot of cases, appendicitis bursting, we see diverticulitis like bursting, we see many cases of stroke, myocardial infarction, and they are not coming to our hospital. Our ER numbers are dropping by 80%. They are not coming to ER. So where are all these patients? So they need to feel safe again to come back. So there's an important message that we send to them.
Bueno, muchas gracias. Thank you. Jorge Castanino, del Sanatorio de la Providencia en Buenos Aires. Jorge, ¿querés hacer la pregunta?
Yes, thank you very much. In Argentina, we have a medium and small clinics. We don't have the possibility to separate absolutely COVID and not COVID areas because we have common areas. What do you think about this situation and elective surgery?
First of all, when you resume, the patient needs to be tested or screened by any means, because if you increase surgical trauma to his current state of possibly having COVID, it might get worse after the surgery. So you have to have this record of if he has COVID or not first. So you need a screening, and you need a screening to put him in a proper place. So at least you need a strategy to separate a floor or a bed that only COVID patients go, or only personnel under investigations go, and one for, we don't use clean word, but like normal. Because if you say something is clean, the other one is dirty, right? So we don't use clean, we use like normal and exclusive for COVID. So this one has to be separate. And once the patient under investigation or COVID goes into a room, it has to be clean, right? So the rotation of the room is severely, it gets really slow. So you have to, if you don't have separate floors for the patients, at least separate rooms for the patients. And it's important also for the COVID rooms or the patient under investigation rooms, they need to be under negative pressure if you don't have a separate aisle for that. So there are small devices that makes normal rooms negative pressure rooms. So we bought more than 100 equipment like that to make normal average rooms for COVID patients. So all our COVID area, they have negative pressure machines in their room. So they don't spread the virus through the corridor or to the floor. Okay. In the operating theater, in the surgical rooms, you have to destinate at least one room for COVID cases. And if you don't have separate operating theaters, you have to control strictly the flow of all the staff and all the patients, so they don't have cross-contamination. So the staff that works in the room, once they go to the changing room, they have to have a proper way to dispose their clothing. They have to take shower or any other protocol your infection control team determines that's the best for the institution. But all of that to minimize all the risk of cross-contamination. If you do not have other way to separate this, or if you don't have a proper way to deal with this separation, other choice is to do a proper screening before and take only negative patients. That this is maybe the last solution for that, but it all depends about your local resources and your local settings.
Thank you. Thank you very much.
Dr. Nazar from Sanatorio Pasteur, Catamarca. A ver. Bernardo, ¿te podrás fijar si le podés dar audio vos? Ahí está, listo.
Ahí está. ¿No escuchan bien ahí, no?
Sí.
Bueno, estamos acá con el doctor Nazar, yo soy el doctor Horacio Campazo, somos los coordinadores y director médico del Sanatorio Pasteur de Catamarca. Bueno, para ponerlos al tanto así rápidamente de los invitados extranjeros, vivimos en una ciudad que tenemos 400.000 habitantes y al día de la fecha todavía no tenemos circulación viral. Eso nos pone con cierta ventaja en cuanto a la cirugía electiva. No tenemos una legislación clara, no contamos de set de PCR y estamos habilitados para hacer cirugías programadas, cirugías electivas. Entonces, ¿qué recomiendan ellos en cuanto a los cuidados y en cuanto a los protocolos para la cirugía electiva?
Okay, let me translate that. Dr. Nazari speaking from Catamarca,
Okay,
a province in the northwestern part of the country. He states that they have no current positive cases in the province, and they have no circulation, and they neither have clear instructions from the government or recommendations. So they are clear to go for elective surgery. And he's asking about your opinion on how to behave in this setting. No cases in the province, no clear recommendations from the government. They are clear to go for elective surgery.
Okay, that's an excellent question. I guess the first and the most important thing is not to be the first case in your hospital, right? During your surgery. So you have to make a very, very strong screening plan, and you have to inform and transmit this plan for everyone that you're dealing it in the safest way. So that's why some hospitals they don't have enough exams, but destining destining any kind of exam so you can document that you're doing the proper effort to do the screening and not increase any risk to this patient. It's gonna be really necessary in this time. So in the later, like no one can be certain. This is really common. If the hospital does not have enough PCR tests, that means that your province, it might not have enough tests also to test all the population. So the situation might not be real. The virus, it might be circulating there and not being detected, right? So it does not mean you don't have COVID cases. It means that they are not diagnosed already. So you have to take care of that and be really careful. And during this pandemic situation, if you do all the proper measures and explain that postponing is not unnecessary, and then you take this decision with the patient and the medical staff to resume properly with all the cautions you make, I guess this is all good for the patient, hospital, and the physician.
Okay, we now have a question from Dr. Alejandro Ciancio that I'm going to translate. Alejandro works, he's the head of the Clínica Modelo de Lanús. It's a private center in the metropolitan area of Buenos Aires. So at the height of the pandemic in proportion to our nation. So here's the question. PCR has shown its best sensitivity at the onset or after the onset of symptoms. As opposed to a higher rate of false negative at earlier stages. So what is the rationale for testing every asymptomatic patient?
Okay. For first of all, PCR is so far the best test we have, right? Everyone agrees with that. So this is what we have right now. This is our best alternative here. Okay, so the purpose of testing a symptomatic patient is to not bring other trauma for them. So this asymptomatic patient, no one knows that if he's gonna go asymptomatic, if any other trauma is given to him. So if this person is asymptomatic, he does not go under surgery, no one knows that he's gonna have any other symptoms. He might not develop COVID. He might go straight and just be cured about that. And then you expose him to the surgery and he's gonna develop COVID, and then he's gonna have a bad prognosis for the surgery and for his own health also. So the main purpose here is not to add one more risk factor for the patient, and also to protect all the medical staff. So if it's really, really hard to do a surgery in an asymptomatic patient, and then for some reason this patient tests himself a couple of days later, and we had few cases here like that before we doing this routine testing, and he calls to the doctor. So he says, "Oh doctor, I've been tested positive." So the physician calls the hospital, when we communicate all the staff and we collect tests for all the staff. So, and then we don't know if he been transmitting this here or not. So this is, we think this is really important for the patient and for the staff.
Thank you. Javier,
I'd like to add to Nam's answer that this screening also send a message of safety to the physicians and for the families and for the patients. So it's a strong message to them that we take care of this issue seriously, and we want to identify every patient, even with even asymptomatic, that have the virus. So I think that's a psychological effect in this measure also. And we didn't charge the patient for this test.
Thank you.
Thank you. Javier Sala Mercado, de Instituto Cardiovascular de Córdoba, nuevamente. Javier, ¿estás ahí?
Yes. So thank you again for letting me ask another question. So you mentioned in your presentations that you have the informed consent that you actually give to the patient. Is this different than the one that you usually give for any type of surgery? Is it something that you develop for the COVID-19 patient area? Do you add a different one? Do you have two informed consents, one for surgery, one for doing surgeries during the pandemic?
Come again. Let me see if I get it straight. If I have different operating theaters for the COVID and for non-COVID, is that it?
No. You mentioned during the presentation that you have informed consents for these patients prior to surgery. Yes. You usually do. But now during the pandemic, is there a new informed consent that you have developed for the COVID area? Is there a modification to the one that you usually used, 2 years ago, 1 year ago, before COVID came?
Yeah, we are studying about the modification to the prior consent, with including all the points about the testing and the risk to being submitted. So this is a new way we like to call. Before we used to call like informed consent. We like to call it like joint consent. So all together we take this decision together. So this is not me informing you about the risk. We are committing ourselves together to take the risk. So this is a good approach of that.
Very good. Thank you very much.
Okay, let me ask you a question. If I got it right, you mentioned that you triage also these surgical teams. how do you do that? How often do you test, if you test the surgical teams?
We have two situations. Since from the very first moment when the pandemic was striking high in the hospital, in the March, there were no tests available in São Paulo, unless in Albert Einstein. So even in that moment, all our medical staff were allowed free have tests anytime they wanted and they needed. So this is one thing that we saved up amount of tests to our staff so they can have access to this test anytime they need it. And the second, we have random checking system for the staff, for all the nurses and administrative staff. They go under a routine random checking. So we can check a small amount of each area routinely, and this is random. We go checking and then testing. And then we have all the social networking about using their work schedule with checking all the positive cases, who was working in which sector with who, and then who's spreading the virus inside with all the working staff. So since you have the working schedule, you can put a layer of COVID positive testing with that and do a simple match and trying to build a network of how the spreading concentrates in your work area.
You work in a very large facility. Maybe you have some 10,000 employees and associates. Could you give us an idea, if you have the information, on the proportion of staff that you test every week or month?
I guess the routine testing, it goes like more than 500 tests a week, but it depends in each area, right? So each area gets like 500 testing, and then it goes by random, circulating week by week in every other setting. But this is all new, right? This is like we have a couple months of pandemic, and we have more than a month in this new normal back to work setting. So this is all new also for us.
So if I can add something about this question. We also have temperature screening in all entrances of the hospital. So all the staff every day are screening for temperature. And if we detect fever, we're gonna put this person in a track to verify symptoms and test them. And we in the beginning, for a few weeks, we didn't apply a rule of everybody using the surgical mask. So the first days, you see a rapid increase of cases in our staff, positive cases. And after the temperature measurement and the rule of everybody on surgical mask, we have a huge decrease of positive cases in our staff.
Is Albert Einstein self-funding for the expense of all these tests? Do you get any reimbursement?
No.
Oh. Wow. Big investment. Okay.
But we're having nice results about that. So as like Dr. Leonardo said, our occupancy rate, it's almost 80% right now. So this is good thing. It works. It works.
Yeah. Okay.
The cost to lose the people, to lose the workforce, it have much higher cost.
Right. Big issue. Okay, Chantal, if I got it right, no more questions on list?
No more questions.
Okay, so again, Dr. Nam, Dr. Leonardo, thank you so much for your time and your dedication. It's been a wonderful session. Hope to see you again in the near future. Maybe we'll be able to invite you to come to Argentina when things come to the new normality. And gracias a todos por la participación y hasta la semana que viene. Chao.
Chao. Buena
Tchau.
jornada.
Muito obrigado.
Muito obrigado. Tchau, tchau.